Hello and welcome to the Retina Radar. I'm Arshad Khanani, Managing Partner, Director of Clinical Research and Director of Fellowship at CRI Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. Today, I'm joined by my friend and colleague, Dr. Nora Ladd, Vice Chair of Ophthalmology, Clinical Research, and Director of Grading at Duke University Medical Center in Durham, North Carolina. Welcome, Nora.
It's a pleasure to be here.
Nora, I'm really excited today because you are a GA and a functional endpoint expert, global expert. And today we'll be discussing new and emerging therapies for the management of geographic atrophy secondary to AMD. And I think our audience will learn a lot today. For this podcast, we always start with some questions about our guests. So first, a few questions we want to dive into is about you, and tell us a little bit about how did you end up doing what you are doing with your retinal diseases?
Well, it's interesting. I may have gone into it a bit different than most. I was doing neuroscience research in my PhD, and I was talking to neurosurgeons because they're working on Parkinson's disease and the treatments are failing in clinical studies. So they advised me to think about the retina as a new frontier for neurodegeneration and potential repair. So here I am.
Yeah, that is not the very traditional route for sure. So I know you have a beautiful family, and you travel a lot. And so tell us two things. Number one, what's your favorite vacation spot? And number two, what's your favorite hobby?
So vacation spot, okay, I'll have to pick. It's hard. Let's say Maui, Hawaii, where we got married, but really any beach. North Carolina beaches are great, Hilton Head, you name it. I've never met a beach I did not like.
That is great. And then what about your favorite hobby? What do you like to do?
I'd say I like art. I'm an art history major from undergrad, and I love to go see art galleries, museums. My favorite period is post-impressionism or symbolism. So Van Gogh, Edvard Munch. I saw that in Norway. They have an amazing museum when I visited Norway next to Sweden for ASRS. So I'd say art.
Oh, wow. Yeah, definitely. That's very unique. And yeah, beaches, you're like me. I can go to any beach, Hawaii, Caribbean. Just put me on a beach and I'm kind of in Zen mode. So, no, that's great to hear. So, okay, so let's just dive into topic at hand, geographic atrophy. Tell us in your thinking, what are the current unmet needs in the evaluation and treatment of geographic atrophy?
So, geographic atrophy is a tough disease, and I learned that it's not dissimilar to neurodegenerative diseases that I was so eager to leave because I thought they were so too complex for treatments, and that was just a difficult task. So, the main unmet need right now is that there are no treatments that improve visual function to date. They may slow down the progression of visual acuity and functional loss, but we'd like something to improve function in these patients. Also, the injection burden is an issue, so we need more durable treatments. We are getting somewhere with the first FDA approvals that started last year, and I'm very enthusiastic about how the field of research opened up in GA. But there are a lot of unmet needs, and we need to learn more about the biology of the disease through imaging, AI, lab work, etc.
No, I agree. I think we're just scratching the surface in terms of treatment options. The approval of pegcetacoplan and avacincaptad pegol was really historical because we haven't had treatment for this devastating, relentless, unpredictable disease, right? And now we do. But I agree with you. I think there are so many unmet needs, and I think it's exciting that there is so much focus now, not only to have better treatments in the future, but also, functional endpoints that we'll talk a little bit later in this podcast that you are a world-renowned expert on, how we can use the right test and how we can actually show functional benefit, and of course, having better treatments that can stabilize or improve vision rather than just worsening of vision. So geographic atrophy, as you said, it's a neurodegenerative kind of disease. And tell us a little bit about pathophysiology and how the complement system plays a role and how complement inhibitors can actually help in this disease.
So you already covered that geographic atrophy is, as an advanced form of AMD, is a neurodegenerative disease and is characterized by loss of photoreceptors and RPE, and we don't know which one happens first, but the photoreceptor loss is more extensive than the loss of RPE, choriocapillaris, And it all results in severe and irreversible vision loss in folks over about 55 worldwide. It results in a huge burden of illness and decreases quality of life. And overactivation of the complement system is critically implicated in the pathogenesis of GA. This was shown by genome wide association studies, which have found strong associations between polymorphisms in the complement pathway and AMD risk, although the association between those and GA expansion is still being evaluated. And it's known that you have dysregulation of complement proteins that results in chronic inflammation, opsonization of cells, amplification of the alternative complement pathway, all which lead eventually to retinal cell death. And the most abundant complement protein is C3, and then the other one that's really important is C5. And those two have been targeted by the current FDA approved drugs. So these are advantageous therapeutic targets because they affect span across all complement activation pathways, even in this disease that's very heterogeneous.
That's the best summary I've ever heard. So thank you. Very, very to the point explanation of the disease and what we are doing to stop it. So let's just dive into the recent approval. Obviously it's over a year for the approval, I believe, February of 2023 for pegcetacoplan, and then August of 2023 for avacincaptad pegol. So let's talk first about pegcetacoplan, obviously studied in the phase 3 Derby and Oaks trials, and we have also seen recent data from the Gale extension study. So can you please summarize the data for our audience on pegcetacoplan that we have to date?
Certainly. So at 24 months in Derby and Oaks phase 3 trials, a monthly pegcetacoplan and also every other month slowed the geographic atrophy lesion growth by 22% and 18% respectively in the Oaks program, and 19 and 16% in Derby compared to sham. In the Gale extension study, we've seen increased efficacy with as few as 6 injections per year. And we noted a reduction in J growth up to about 42% during the months of 24 to 36. So there seems to be an acceleration of treatment effect over time, which is a good thing to explain to our patients when we discuss the need for chronic injections.
No, that's an excellent summary. So Nora, there was microperimetry that was also part of the Oaks study, correct? And tell us what we learned from that. Obviously, in terms of some of the analysis were pre-specified and others are post-hoc. So can you just summarize, like, what did we learn from the microperimetry that was mandatory, I believe, in the Oaks study, correct?
Right. So the Oaks program employed microperimetry, and what is shown in a post hoc analysis, so not a pre-specified analysis, was a reduction in increase in number of scotomatous points in the perilesional area, and also a reduction of loss on mean sensitivity. So retinal sensitivity loss was decreased significantly by pegcetacoplan compared to sham. And this was an important finding that I think could be explored in future programs of GA. And now we have a better understanding of protocols and what grids to employ and how to better analyze data. At that time, we used a broad grid that encompassed the entire area, but now we can do more patient-tailored grid or really focus on that perilesional area with more precision.
No, I think that's important, right? I mean, I think microperimetry continues to get better and better and customize, patient focus, patient, grids are probably the way to the future. But, I'll tell you, as a clinical site with so many studies with microperimetry still is a challenge. So I think as a field, we continue to have testing that's easier and protocols that are quicker, because I think many of our patients that are elderly get tired. I think everybody believes, right, Nora, that complement inhibition, GA, slowdown of GA equals slowdown of vision loss or functional vision. But I think it's just that we haven't had a test that has shown that in a pre-specified prospective fashion, correct?
Correct. Not in these phase 3 programs. This has been shown in a more recent phase 2 program that of a drug that's not FDA approved, but we do have post hoc data on ellipsosome loss, which is loss of photoreceptors. And there was a statistically significant difference that pegcetacoplan slowed down the progression of photoreceptor loss as early as 4 months, versus RP loss was only seen at 12 months. So to me, that's promising. You're right. We don't have pre-specified functional data on these phase 3 programs, but we do have post hoc on microperimetry, and we have post hoc data on ellipsoid zone loss that I think is quite promising.
No, definitely. And I think the field is moving towards more in that direction. And of course, the ellipsoid zone, the recent acceptance of easy attenuation as an endpoint by FDA also kind of proves that. So, okay. And then what about in general safety? I know complement inhibitors increase the risk of CNV, and we did see that in Oaks and Derby. Any other adverse events or anything in terms of safety overall from the pegcetacoplan program?
Yes. So in addition to exudative, macular degeneration, so MNV, we've seen a small risk of occlusive vasculitis with vision loss in a small number of patients, and then some cases of NAION. Now, these are rare, but obviously something to pay attention to.
Correct. And we did not see vasculitis in the trials, or we have not seen it in Gale, but in the real world, right?
In the real world, that's what I mean. So we did see NAION, but this is an age population. So these, again, are very rare events, and it's hard to hang our hat versus this is just a common, not a common occurrence, but something that happens in the age population as part of the natural history.
No, I think that makes sense. Okay, so what about avacincaptad pegol? Gather 1 and Gather 2 studies met the primary endpoint, receive approval last year. Can you summarize the data? And obviously, you also mentioned that C3 and C5 are good targets. Obviously, pegcetacoplan targeting C3, and then avacincaptad pegol targeting C5.
Yeah, so in Gather 1 and 2, so avacincaptad pegol was well tolerated and showed significantly slow geographic atrophy growth over 12 months compared to sham treatment. In Gather 2, at year 2, the drug monthly and every other month showed a 14 and 19% growth reduction, respectively.
It's interesting, right? Like Gather 1 was an 18-month phase 2/3, and then Gather 2 was a 24 months. We were part of both trials, and it was interesting how the design was for Gather 2, where patients were re-randomized after 1 year. So in the first year, it was sham versus monthly, and then re-randomized to have sham, the sham stayed in sham. Of course, there was some dropout, but re-randomized to monthly and every other month dosing, which was interesting to see that both monthly and every other month was helping the patients, but every other month demonstrated, more reduction. And I think when I presented the data, I wanted to look at that, and what we found that patients got re-randomized to every other month actually had a better response in the first year also. I think for me, the key takeaway was that over 2 years, we saw the doubling of treatment effect compared to over 1 year. And I think, as you said, I think early treatment is the way to go. In terms of safety, Nora, any safety things other than the MNV as we discussed with complement inhibition?
Not in these Gather 1 and 2 programs, so the drug was very well tolerated.
Yeah, no, I think that's something we noticed too in the trial. So of course we have now pegcetacoplan available, avacincaptad pegol available. So tell us your experience with both drugs, as well as share with us some of the recent real world data that was presented at American Society of Retina Specialist meeting.
Yeah, so my personal experience, I'll start with my clinical experience, is that both drugs are well tolerated, and generally the patients interested to receive them like to be very proactive. Most of them choose monthly administration for both, especially in at the minimum one eye that's most at risk. So some of the patients choose to have pegcetacoplan every other month because it is difficult to present to clinic more often for injections.
Got it. For me, it's been learning over the last year that patients are actually super motivated. The ones who want the treatment, they're super motivated, and it's more patients than I expected. I thought that with the modest efficacy we have seen with these drugs, patients won't be motivated. But in my experience, there's a lot more interest from a patient perspective than I thought. What are your thoughts on that?
I agree. So in my practice, patients self-select and self-refer for treatment because it might not be as common in their area, or they hear about our institution and want to come for care, and they know we offer the FDA-approved recent drugs. So there's been a lot of enthusiasm in my practice, and again, I've had no safety events. I've had no episodes of inflammation, occlusive vasculitis, and AION. They have Both drugs have been well tolerated. We know some numbers now from ASRS, from real world data from RCA and Mid Atlantic, and that study analyzed 60 over 6,500 patients, 89 over 8,900, almost 9,000 total eyes, and 32,000 injections. The mean age of the participants is consistent in my practice, which is about 82.7. So elderly folks. Mean visual acuity 20/50. And 21% of these patients actually had active treatment with anti-VEGF. And I don't know if that was in the fellow eye, but I'm assuming so, in the eye that's not receiving treatment for GA. But the average treatment interval was 45 days. So, in 853 eyes, so 9.49% stopped therapy during the study period. 296 developed new CMV, so that's 3.3% risk per eye, and 29 developed some mild intraocular inflammation, 0.4%. There were 4 cases of retinal vasculitis. So this is a per patient level of 0.06%. It's useful to have these numbers to see some real world data for the first time. As far as avacincaptad pegol, we don't have yet real world data that I'm very familiar with, but I know over 100,000 vials were shipped. It's been exactly 1 year since approval today. And to my knowledge, there have been no occlusive vasculitis or NAION events with this particular drug.
No, I think that's a really good overview. I think the real world experience is super important, right? Because we are looking at very heterogeneous patient population. And, I was also interested in seeing that 21% were of the eyes that were getting, pegcetacoplan in this database, results were actually on concurrent anti-VEGF treatment, which was interesting. I think many of the patients who are on anti-VEGF over time obviously get macular atrophy, and it seems like the drugs are being utilized in that situation. We don't have any data in that patient population because obviously neovascular AMD was an exclusion in the trial, but it's very interesting to see. One thing that was interesting for me per se was the IOI rate. Was actually lower than the trials, which was very interesting at 0.4%. And then the retinal vasculitis rate, obviously 0.06. It's about 1 in 1,600 patients, and there's a large number of patients here. So I think these numbers really help us, in terms of discussing risk and benefits of pegcetacoplan with our patients, and of course, looking forward to having data from real world for Avacin kept at Pagol. So, Nora, let's move on for the next few minutes at the end of this podcast. Tell us a little bit about, in terms of imaging, and you're very involved with the functional endpoints, and what are you excited about when it comes to imaging, and how AI and all these different biomarkers will be used in management as well as in getting new treatments for GA in the future?
So I think AI will help in this tough disease. The impetus for all of us as clinicians to image a lot and obtain high resolution images that can be used for AI algorithm development. So I mentioned photoreceptor loss. At some point, I like to have these maps, just like with autofluorescence, to be able to show the patients their GA area and how it expands over time. I like to have these maps of photoreceptor loss and show a slowing of progression of loss over time. If we can have a movie, what she would look like without drug and with drug, and plot it out so they can see that their treatment is slowing down disease progression. I think that'd be very useful for standard of care. And then for clinical trials, also for future clinical trials, I think we're getting better at patient selection using imaging and stratifying patients based on OCT and autofluorescence and these EZ maps that we can obtain on OCT. OCT angiography is also useful to pick up the patients that are at risk, the ones that might have non-exudative MNV because we know there's a risk of seeing conversion to wet macular degeneration. So we want to keep an eye on these at-risk eyes. So those are, I think, the imaging technologies I'm excited about. Probably would add microperimetry in the future. I don't know how easily implementable would be in a busy retina practice, but perhaps we can co-manage patients with optometry or other professionals so we can give the patient a functional readout of their disease and have some algorithms that show how they would progress with or without treatment.
No, I think that's excellent. I think all of those are very relevant as we move towards obviously treatment of patients with current approved treatments, as well as looking for new therapeutic targets, as well as new drugs. So, what are you excited about, Nora, in terms of ongoing trials and new drugs that are in the pipeline that may be able to be available if the trials are positive over the next 5 years or so?
Well, I'm excited about quite a few programs out there. The ones that are addressing neuroprotection as a strategy are particularly enticing because we like to prevent vision loss. We'd like to see pre-specified visual function readouts, and they have proven promising. I like to see earlier diagnosis of GA, so lesions that are extrafoveal and smaller, so try to address GA earlier. I like to you know, to think about being proactive with imaging, even clinically. So we have more images, so AI can help with algorithm development. And generally, just treating this disease earlier, perhaps even in the pre-GA stages, intermediate AMD high risk, or CRORA before GA onset, before photoreceptor loss, before that loss is irreversible.
No, I agree. I think, again, as I said earlier, it's a relentless, unpredictable, progressive disease. And I am, obviously very excited about the future. Lots going on in terms of imaging, biomarkers, functional endpoints, as well as development of new drugs. And of course, having two currently approved treatments have really helped give hope to our patients who are suffering from this disease. Obviously, efficacy is modest for both, and we have to discuss risk and benefits with each patient and figure out like if they're good candidates for treatment. So before we end the podcast, Nora, just again, you have achieved a lot at Duke, being in academics. You have trained a lot of residents, a lot of fellows. You're well renowned in the GA space. Tell us what career achievement you're most proud of.
Well, that's very kind of you to say. Probably and relevant to this conversation is the fact I contributed to the OAKS program as a PI of that study that gave us the first FDA approved drug for geographic atrophy. I think it is the end of the beginning, and the future is bright for this disease and perhaps for dry AMD in general. I'm very hopeful for that.
Something you should be very proud of, bringing the first treatment to our patients for a disease that had no treatment. So yes, I think that's a huge career achievement, and obviously being a first co-author on the Lancet paper and then seeing the drug available. I think it's very exciting, right? When you're involved so closely with some program and now you have the drug available for the patient. I think it's so exciting because it's so hard to get there. Majority of the programs fail, and taking it to the finish line and bringing it to the patient. I totally agree with you. I think it's very rewarding. And then, you're too young in your career still, but down the road, decades and decades later, how do you want to be remembered by people once you retire?
Well, before I answer that question, I'd like to obviously mention that you contributed very significantly to the Gather programs and your PI on those programs. So, congratulations to you. And I know patients are very grateful to you for bringing that drug to the market. Very safe and well tolerated. But I guess how many of us want to be remembered is as clinicians, and in my case, clinician scientists, because of my background, that change the standard of care of patients. And in this case, I like to improve the standard of care of patients with this tough degenerative disease of the retina, which is geographic atrophy, and moving it earlier to intermediate AMD so that we can prevent perhaps a late disease altogether, both wet and dry.
No, thank you. Thank you for the kind words. Yeah, I mean, it's nice that between you and me, we are able to help patients bring, treatments. We were also part of the pegcetacoplan trial, and I think you also contributed a lot to the Avastin kept at Pegol. I think what I'll tell you, and you're very kind. When I think about you, I think of you as a super smart, kind clinician who's very collaborative and very open to innovation. So that's how I would describe yourself. You're being kind by not bringing those qualities. I think you're unique because not only you're smart, but you are a pleasure to work with. So thank you, Nora, for excellent discussion. Thank you to the audience for listening in. Please remember to take the post test and evaluation to receive CME credit and to tune in for additional episodes within the podcast series. Thank you again, Nora.
Thank you. It's been a pleasure.